Welcome to Eye Contact. I'm Henahan. Small eyes can present big challenges to the cataract surgeon. Today I'm joined by Dr. Soosan Jacob, who will tell us everything we need to know about Phaco and small eyes. Welcome, Soosan.
Thank you, Sean. Thank you so much.
Perhaps we should start by defining what we mean by small.
So, Sean, small eyes can be, classified as microphthalmos, relative anterior microphthalmos, and hyperopic eyes, basically. So, there's a lot of difference between these categories. Microphthalmos is an eye that's completely small in all its aspects. The anterior chamber is small, the rest of the eye is small, the axial length is small. Relative anterior microphthalmos is different in that only the anterior part of the eye is small, the anterior chamber depth is shallow, but the back of the eye is normal. Now, in both these conditions, the lens occupies a large space in the anterior chamber. So, it is essentially the lens is normal sized or maybe even larger. So, it occupies a lot of space, and so there is a crowding of the anterior chamber, pushing forwards of the iris, peripheral anterior synechia development, chronic angle closure glaucoma, and all these kind of things in these situations. And the third, the hyperopic eye, basically has a normal anterior chamber depth, but a short axial length. So, that's a completely different category. And if you just look at microphthalmos again, you can also have complex microphthalmos, where there may be syndromes where the child also has a lot of other things like corneal opacities, retinal problems and all those things. It could be coloboma, it could be associated with a coloboma microphthalmos with coloboma, or just a plain microphthalmos like nanophthalmos.
I can see how all of those would create a lot of challenges for the surgeon. You might have to break it down, but what would you be thinking in the pre-op stage?
Right. So, now one of the situations that a doctor often comes across, or once in a while at least, is nanophthalmos, which is an eye that's small all over. It's otherwise normal except that it's completely small. So, these are eyes which are prone to a lot of complications. They are very hypermetropic patients. They have powers of 10 to 20 diopters with glasses itself. So, you can assume that the intraocular lens power is really going to be extremely high. You sometimes, most often, do not even get lenses of those powers available commercially. So, you sometimes have to customize them. You might have to do piggybacking of these lenses and so on. And also they are also prone to a lot of risks of surgery, in the sense that they have a thick inelastic sclera and a thickened choroid. So, you have this risk of intraoperative uveal effusions developing. So, this is a major risk. As I said earlier, the lens is large, so you do not have much operating space in the eye. There is a lot of potential for damage to the endothelium, damage to the posterior capsule. And basically there is not much space. Sometimes eye may be so small that you do not even have space to put in the lens. So, these are there are so many considerations that you have to think about. You have to make sure that the intraocular pressure is lowered, the blood pressure of the patient is lowered with all possible means at your disposal, and you put these pre-placed sclerotomies or sclerectomies so that you can handle an intraoperative effusion syndrome if it happens.
These sound like terrible cases for a beginning surgeon.
Right, yeah, absolutely.
How do you handle the biometry?
Yeah, that's a very interesting question. So, when you look at the biometry, you have to do both an optical as well as an immersion biometry in these patients. And what you still have to remember is that you may never be accurate. You may still never be on target. So, this is part of the preoperative counseling that you have to do to the patient, that you are not going to get an accurate biometry, and you have to use formulas that are different from the usual ones. So, you might tend more in favor of the Hoffer Q or the Hayes or the Holiday 2. For these eyes, and you still have to know that you may still be wrong in your IOL power calculation. The other thing is the IOL power that comes is generally so high, as I said earlier, that you are not going to be able to get that IOL. So, then you have to make the choice of putting in either piggyback IOLs at the same time, which means the larger power IOL within the bag and the thinner whatever the residual power is in the sulcus, or you leave just the maximum power that you can get in the bag, and then you go ahead and assess the refractive status post-operatively and put in the residual an IOL for the residual refractive error post-operatively in the sulcus.
With these complex procedures, what are the complications, the operative complications you're most concerned about while you're going in?
So, as I said, nanophthalmos is a completely separate entity where you have this very high risk of problems happening, also considering the fact that they can have retinal macular hypoplasias and all. Even the final visual acuity that you get may be limited. When you're looking at other eyes which are hyperopic eyes, where sometimes what can happen is they might have a slightly shallow anterior chamber, you have less space to operate. So these are again situations where you have to change your phaco maneuvers slightly. You would want to make better tunnels, longer tunnels which are well constructed, which don't leak, so that you don't keep getting iris prolapse consecutively. You have to account for the fact that you have a shallower anterior chamber, and maybe use a soft shell technique where you use a visco-cohesive or viscoelastic for maintaining space, and a visco-dispersive for protecting the endothelium. So that gives you space as well as protection to the endothelium. And you would want to work more in the bag so that you are far from the endothelium, and use higher fluidics machines so that your chamber is always well maintained.
Is there any place for the femto laser, either with the capsulotomy or any other stage?
Femto laser can be useful in eyes with soft cataracts, especially as the rhexis is sometimes difficult to get, because there might be a positive pressure as well in these patients, and there could be a chance for rhexis run out. So that's a useful place to use it, so that you're sure that you're getting a rhexis well rounded and you're certain that you're going to be having that round rhexis. And the second thing is that it can also help in nuclear disassemblies. For instance, if you've got a hard cataract in a hypermetropic patient, you don't want to do all that, you want something to help you out, and that's a perfect place for the femtosecond laser to help you.
So best possible scenario, how do the patients do? Maybe the hyperopic eyes are more predictable?
The hyperopic eyes definitely are more predictable. I would say many of the hyperopic patients are very happy with their surgery, because they've been those patients who've never seen well throughout their life, either for distance or for near. So when you actually do the surgery for them, they're pretty happy with their results. There can be room for IOL errors, as I said, and you have to counsel them and maybe look for other ways to correct those refractive residual errors, maybe through corneal based refractive surgery, or just you try to give them glasses or whatever. But on the whole, they are happy. So there are a lot of people who also do a clear lens extraction once the hyperopic patient starts to lose accommodation, because now without accommodation the lens is really not doing much for them. And at that age you might consider just doing a clear lens extraction and placing in an intraocular lens to account for their refractive error as well. And that's actually a better procedure than LASIK for those patients, because LASIK has its problems for hypermetropia, unpredictability, regression, and so many things. So that's an option, and patients are generally happy.
As long as you can find an IOL that will fit.
Right. But for plain hypermetropia, it generally does work out. Those IOLs that don't fit, the high power IOLs, are generally for those nanophthalmic eyes and those extreme microphthalmic eyes.
Right.
So we have to remember that these are two separate sets of patients, hypermetropia and microphthalmos.
Right. Well, thank you for walking us through that.
Thank you. Thanks, Sean.
And thank you for joining us. For more information on this and related subjects, please see us at eurotimes.org.